Hello, I'm Rear Admiral Paul Reed, Director of the Office of Disease Prevention and Health Promotion. Thank you for joining me for another installment of our video series that complements our monthly Health and Wellbeing Matter blog, where we meet with partners from across the public and private sectors to discuss work helping to advance health and well-being for all people. It's November, and we recently celebrated Veterans Day, a day that honors the individuals who have served in our nation's military. Military service involves a range of physical and mental demands that can take a toll on members' health, even in peacetime. And just like their civilian counterparts, many veterans live with chronic physical and mental health conditions despite their history of uniformed service with all the added physical training and mental fortitude. Regrettably, veterans are not immune to the many inequities that exist across this nation and the disparate outcomes due to those inequities, including when it comes to their health. That's why today I'm pleased to welcome Dr. Ernest Moy, Executive Director of the Office of Health Equity at the Veterans Health Administration, to discuss the health challenges that our veterans face and what we can do to address them. Dr. Moy, really appreciate you joining us.
It is a pleasure to be here. Thank you so much for this honor.
Sure. So, as background for our discussion today, could you tell us about the rates of chronic disease among military veterans, and what does that big picture look like in terms of the health status of veterans in the U.S. today?
Okay. Well, I'm going to start by telling you why I can actually tell you about the health of veterans and compare it to non-veterans, because we in VA only have information about the health of the veterans that actually seek care with us. To understand the veterans who don't get care from us, veterans as a whole, and compare them to the general population, we have to look outside of VA. And we have a number of partnerships that help with that. So we have a partnership with the CDC National Center for Health Statistics, and we have a veteran health information site where comparisons of health of veterans and non-veterans are presented. We also have a partnership with the Agency for Healthcare Research and Quality, and we produced a veteran health chart book that compares the healthcare quality of veterans with non-veterans. And I'm going to tell you information from those two different sources. So as you alluded to, military service takes a huge toll on the bodies of its participants. And we see this after they become veterans in the high degrees of pain and arthritis that are reported by veterans. They're also more likely to report that they're unfair to poor health. We also know that veterans are exposed to different toxic exposures that non-veterans are not exposed to. So as part of the PACT Act, we're doing a lot of screening for toxic exposures. And of the 44 million veterans that have been screened so far, over 40% report some kind of a toxic exposure.
Wow.
And this may be reflected in the higher rates of cancer among veterans. Veterans often also have higher rates of chronic conditions like hypertension, diabetes, and coronary artery disease compared to non-veterans. On the plus side, veterans are more physically active, and they're more able to access healthcare services, in part due to the VA.
Well, you alluded to it, and so I'm going to ask you the question. Disparities in health outcomes are unfortunately widely different across the United States, and significantly influenced by individual social circumstances, some of which you spoke to just now. What has the VA observed regarding health disparities among different service member demographic groups? And can you give us an idea of how that may even differ, if it does, with civilian populations?
Sure. Again, using these sources as well as our own data, we can talk a little bit about how veterans are doing from a disparities perspective, as well as how that compares with the civilian sector. And so I'll talk about 4 different kinds of disparities. So one kind of disparity is having a disease, prevalence of different chronic conditions. And here we mirror the civilian population. So Black, Hispanic, and poor veterans are more likely to have many chronic diseases compared to white and non-poor veterans, as similar to in the non-veteran community. From an access to care perspective, we see that there are large differences related to race and ethnicity and socioeconomic status among non-veterans. Among veterans, access to care is actually quite comparable for different racial and ethnic groups, and there are differences depending on socioeconomic status, but they tend to be smaller. When they actually get care, the quality of healthcare services for those veterans that receive care through our system tend to be very not disparate. Almost all of our veterans receive roughly the same processes of care, and this is unlike the civilian sector where we do see very large differences across different populations. But I will emphasize that even as we're getting exact same services, the outcomes of care that we see are slightly different. So Black, Hispanic veterans are less likely to have good control of their diseases, even as they're receiving the same services as white veterans, for instance.
You briefly mentioned one of the specific chronic diseases is diabetes. And regrettably, diabetes across the United States is increasing in prevalence, as we all know. But it is particularly challenging for veterans. As I recall, it may impact as many as a quarter of the veteran population. Can you share some additional data with respect to diabetes in particular, and describe how the VA is approaching innovation around therapeutics and interventions for those that suffer from diabetes, and maybe a little bit about what you're doing in innovating around prevention for those that haven't yet succumbed to diabetes?
Yeah, so what we see in diabetes is very similar to what I described for diseases overall. And so just like in the general population, Black and Hispanic and lower income veterans have higher rates of diabetes compared to white veterans and non-poor veterans. When they come into our system and they receive care, unlike in the civilian sector, we see almost no differences in the care that they receive. So Black and Hispanic veterans are receiving the needed services like eye examinations and foot examinations and renal assessments at the same rates as white veterans. But again, the outcomes that are achieved are different. And so even as they're getting the same good quality care, Black and Hispanic veterans are less likely to have their glucoses under control and their blood pressures under control. And so the big question is why, and what can we do about it? And we think that different groups of veterans face unique barriers to doing the things that they need to do, taking their medicines, taking the right medicines, complying with diet and exercise. And we think that it's a matter of taking what we know we can do well, because we're doing it well for some veterans, and making sure that all veterans can gain those benefits, making sure that it resonates with all of our veterans, that they can, do the things that they need to do to stay healthy. And some of the ways that we're doing this are, for example, we have a MOVE program of longstanding, which tries to help veterans lose weight, to prevent diabetes, and to manage their diabetes, after it's diagnosed.
Terrific. Speaking my language now.
Yeah, and the most important thing.
Yeah.
And in general, a lot of the programs, it's a good program, but it tends to be kind of generic. And some innovative VA medical centers are developing unique products to support it. So very specific cookbooks and a cooking channel for different groups of veterans that really kind of speaks to them and can help them be compliant with all the horrible things that one has to do for a diabetes diet. We also try to focus on particular kinds of intervention. So we noticed that SGLT2 inhibitors are really important for people with diabetes that have a lot of comorbidities and are at high risk for developing renal disease and heart disease. And when they're on these medicines, it really reduces the rate. So they really, really should be on these medications, this group of high-risk veterans. And we've known that these medications are underutilized in VA, and there are differences, that Black and Hispanic veterans are less likely to be on these medications. And so one of the things that we do is we work with clinical pharmacists to do outreach to veterans in general, but targeting specific groups of veterans to get them on these medications, to educate them about them, to at least give them the option of being on them. And when we do this special outreach, we were able to increase the rates, and there are no disparities. With the special outreach, everyone wants to be on these medicines and can be on them, and and it'll help us in the long run because they won't develop renal disease and heart disease. The last thing I'll mention is sometimes we work with innovators to try to develop solutions. So we knew that rural veterans and minority veterans are more likely to have foot ulcers, diabetic foot ulcers, and amputations. And part of that's related to their ability to check their feet or come in to get their feet checked. And so we have remote monitoring mats that we can send out to veterans. They stand on them each day. An algorithm assesses the temperatures in their feet and gives some kind of score about their likelihood of developing a foot ulcer. That information is transmitted centrally to a provider, and the provider can then call them if there's warmth in one of the feet to make some kind of an intervention. And in this way, we can improve care for the veterans and decrease disparities.
It's amazing where technology is getting us.
Yeah.
What percentage of veterans are able to be reached with that sort of technology?
So it's just starting to ramp up, and so we have, I think, tens of thousands of veterans now on it, but we're starting with the highest risk veterans, and so it's still just it's a small proportion of the veterans. We have this whole algorithm about your past history of ulcers and amputations and such not. It's a small number, but we're trying to really increase the numbers quickly.
And you're developing a proof of concept, right?
Yeah.
Well, so diabetes is clearly an example of how access to care and quality of care can make a big difference. You just made a great point of that. But clearly access to care, even high quality care, is only going to do so much. It's not the entire answer to the problem. How is it that the VA is approaching social determinants of health, those upstream issues that are influencing? You more than alluded to some of them, like adequate housing, like social connectedness, economic stability. Is the VA approaching those factors in complement to all that high technology and quality care?
Mm-hmm. Yeah, it is. And I'll tell you, I came to the VA because it's not just a healthcare system, it's also a social support system. And so we are able to help veterans get housing, get food, help them get education, get a job, connect them with our veteran service organizations, with people who can help them if they're socially isolated. Mm-hmm. So it's more than just a healthcare system. But part of the problem is we have to know who is having these social needs. And historically, VA has screened for housing and food insecurity, but only recently have we started to screen for 9 different social determinants of health. We have an ACORN screener, and we are rolling this out throughout our system to really ultimately to try to screen every single veteran in our system for these 9 social determinants of health. This information is then stored in our electronic health record so that when a provider speaks to a veteran in future, they have this information available to them, and they can then incorporate it into the treatment advice that they're giving. Mm-hmm. One of the
like some of those nutritional issues you mentioned.
Exactly. So yeah, why offer this way that their medications and their diet and exercise can really be provided in the context of their living situation, their working situation, mm-hmm. et cetera. I'll say it's of interest. The most common social determinant of health that we're screening positive for are digital technology issues.
Oh yeah.
Yeah. And we have a digital divide consult service that we can refer veterans to, and they can help them to get these things. They can help them actually get devices, help them with increased connectivity, help them get training, mm-hmm. Connecting them with VA Video Connect. And so really trying to hit on that first, most common social determinant of health.
That's tremendous. I'm interested. There is this distinction between the Veterans Affairs and Veterans Health Affairs. What percentage of those interventions that you talked about are in one camp, in one part of the organization versus another, or do they blur the lines between big VA and VHA?
Yeah, so we're actually, we have our silos, I have to admit that.
Yeah, well.
But when we're taking care of an individual veteran, we have to be able to cross those lines, and we try to do this as best as we can. A lot of VHA extends into the social determinants, mm-hmm. and so we do help with directing them towards housing support, or about 40 of our VA medical centers actually have food banks inside of them. But often there has to be a handoff. So if a veteran wants to use their educational benefits, we have to hand that off to VBA. Mm-hmm. Many facilities actually have these services integrated in the same location to make it a little bit easier.
Mm-hmm. Yeah, terrific. So many of us have veterans in our lives, friends, family, loved ones. What would you recommend to Americans out there who share their lives with veterans in ways that they can help veterans live healthier lives?
Okay. So first of all, connect with veterans. That's always important, mm-hmm. but I'll put our bias in. You should connect with the veteran using our whole health approach.
Yes.
And so instead of asking a veteran, what's the matter? Ask the veteran, what matters to you? Sure. Instead of asking them, how are things going? Ask them where they want to go. Because I think if we understand...
I think you need to repeat that line. That's a powerful line. Can you say that again? Where they want to go?
Where they want to go.
Yeah, as opposed to where they're at.
Yeah.
Because that's tremendous.
If we understand, what matters most to a veteran and where they want to go, I think then we can support them on this life journey. Uh-huh. The other thing I'll say...
In little and big ways, I'm sure.
Yes, yeah. Right. We do a lot of different things, and not instead of saying, this is what we want to do for you, it should be like, what do you want to do and how can we help you get there? And the other thing, I'm channeling my boss. And so he says, at the end of every one of our team meetings, go and hug someone you love.
I love that.
So I would say, go hug a veteran. I know that for me, the best part of the day is when I greet my wife at the end of a long day and give her a hug. And so Go hug a
That
veteran.
sounds like the best advice.
And I don't know if I know you well enough to hug you, but I certainly want to give you a handshake to just express my deep gratitude for your past and current service.
Thank you very much. Appreciate it. And very much appreciate you providing us and our viewers further insights into what Veterans Health is all about and what we can do to improve upon it going forward. Sounds like you're all doing tremendous work. Thank you.
Thank you.
To learn more about health equity, social determinants of health, and related objectives, please visit healthypeople.gov. To learn more about the VHA's Office of Health Equity, please visit va.gov/health equity.
Produced by the U.S. Department of Health and Human Services.